Welcome to the Fracture Prevention Central webinar, How Transitioning to the ICD-10 Coding System Will Impact Your Osteoporosis Practice. Fracture Prevention Central, brought to you by the National Bone Health Alliance, is made possible through support from Amgen and Eli Lilly and Company. And now, I'll introduce you to Debbie Zaldo, Senior Director, Clinical Programs for the National Bone Health Alliance. Debbie?
Hi, everyone, and thank you for joining us today for Fracture Prevention Central's webinar, How Transitioning to the ICD-10 Coding System Will Impact Your Osteoporosis Practice. As many of you know, NBHA launched in late 2010 as a public-private partnership that brings together the expertise and resources of its public, private, and nonprofit sector partners. Our collective reach is over 100,000 healthcare professionals and 10 million consumers. NBHA uses its collective voice and diverse membership base to weigh in on subjects important to bone health. NBHA's vision is to improve the overall health and quality of life of all Americans by enhancing their bone health and addressing the priorities of the Bone Health Summit National Action Plan, which is to promote bone health and prevent disease, improve diagnosis and treatment, and enhance research, surveillance, and evaluation. Fracture Prevention Central was launched in March 2013 to enable sites to implement a fracture liaison service in support of NBHA's 2020 vision to reduce fractures 20% by the year 2020. The Fracture Prevention Central site helps healthcare professionals and administrators implement a coordinator-based post-fracture FLS model of care to reduce secondary fractures and the associated costs while increasing patient outcomes. Fracture Prevention Central is packed with a host of materials from a successful domestic and international post-fracture care programs for everyone to use. And as you see on the slide, we have different links for some of the key areas that you will find on the site. The site also highlights the work of leading FLS programs, including the American Orthopedic Association On the Bone Program, Kaiser Permanente, and the Geisinger Health System. In fact, we have a host of over 100+ brochures and materials that the Kaiser Permanente program has posted on the site for everyone to use. In addition, all the Fracture Prevention Central webinars are available on demand and free of charge. Before I introduce our speaker today, I wanted to share that our next webinar will be on October 1st from noon to 1 p.m. Eastern Time, and will focus on the NOF NBHA Qualified Clinical Data Registry. We hope that you'll join us to hear what you need to know about QCDRs and how the NOF NBHA QCDR can make it easy for you to participate in PQRS, maintain certification for Part 4, quality improvement, as well as supporting better outcomes under the Value Modifier Program using a QCDR. Now I'd like to introduce our speaker today, Ms. Anita Henderson-Sumter. Anita is a certified professional coder and certified in healthcare compliance. She is currently employed with the American Association of Clinical Endocrinologists as the Director of Socioeconomics and Member Advocacy, providing staff support for over 6,000 endocrinologists nationally and internationally. Mrs. Henderson-Sumter is responsible for coordinating activities of healthcare financing, third-party reimbursement, legislation, regulation, and other factors that affect the practice of clinical endocrinology. Anita previously worked for Cigna Healthcare as a senior provider service representative for 2.5 years and was previously employed with First Coast Service Options, Inc. for 21 years. Before leaving FCSO, Ms. Henderson-Sumter worked in the capacity as Senior Provider Relations Representative. She was also a liaison between FCSO and various medical societies and associations. We are thrilled to have Anita join us and share how transitioning to the ICD-10 coding system will impact your osteoporosis practice. Anita?
Thank you, Debbie. And welcome everyone to the How to Transition to the ICD-10 Coding System and how it will impact your osteoporosis practice. Today we're going to talk about some basic information in regards to how ICD-10 is going to impact your office, and also things that you need to consider and discuss with your physician, your office staff, whether it's your front office, back office, billers, coders, and how you can make this a very as smooth as possible transition in regards to ICD-10. Just taking a look at the agenda, we're going to talk about the basic medical record concepts, medical necessity and why is it important, and documentation, details, and enhancements for osteoporosis and fractures. So the first thing we'll look at is basic diagnosis coding concepts, and this is something that applies across the board. It's not just specifically to osteoporosis and fractures, but in regards to other conditions that you may encounter or treat for a given patient. First and foremost, it's all about medical necessity, whether it's the Centers for Medicare and Medicaid Services, CMS, or your private payers, Blue Cross Blue Shield, Aetna, Cigna, whomever the payer may be. They're looking for medical necessity. Basically, why was the service or procedure performed? Why was the supply given? And that equals out to your diagnosis codes, whether it was ICD-9, which we currently use, or which we will be using, ICD-10. So just to give you a definition of what the government considers to be medically necessary, it's for the diagnosis or treatment of illness or injury or to improve the functioning of a malformed member. And this is directly out of the Social Security Act. In addition to that, and I've clicked too many slides, who determines medical necessity? Well, basically, it's physicians and other qualified healthcare professionals. You're the ones that determine which services and procedures are going to be performed, determine which drugs, supplies, equipment that are going to be provided during a given patient encounter, and then you make the determination of a diagnosis based on test results, whether they're lab tests, diagnostic, radiological services, whatever the case may be, and then treat the patient's conditions based on that information. Now, if you don't have a definitive diagnosis, of course, you should code based on your signs and symptoms. This has not changed or will change for ICD-10. And you want to make sure that all of this information is captured in the patient's medical record. So, going a little bit further in regards to medical necessity, it has to be supported by documentation in the medical record. So it has to be a justification as to why you're doing what you're doing. You're performing a given service, but it has to be medically necessary, whether it's based on the patient's condition or it's based on, as I mentioned before, lab or test results. It may or may not be supported by clinical guidelines. As you know, some payers do use some of the specialty societies' clinical guidelines, position statements, and some don't. They do base their judgment based, or they use their judgment based on data that they may have seen, or if CMS has developed particular guidelines. Most of the time, the private payers follow what CMS does. But as I mentioned, it may or may not support those clinical guidelines. It meets the standards of good medical practice. Is it properly and needed for the diagnosis or treatment of the patient's condition? It must be furnished for the diagnosis, direct care, and treatment of the patient's medical condition, basically. That's what it's all about, medical necessity. And it's not for the convenience of the patient nor the provider or supplier. Those are considered not to be medically necessary if it's a convenience. And those are things that it's up to the physician whether or not they're going to provide that service, or if the patient is willing to pay for that service. Now, in addition to that, Medicare also provides further information or clarification in regards to medical necessity. Although furnishing a service or test may be considered good medical practice, Medicare generally prohibits payment for services without beneficiary symptoms or complaints. Basically, if there was a chief complaint, the signs or symptoms, this is what Medicare is looking for in order to pay for a given service. Now, all CPT and HCPCS codes submitted to the payers must be supported by the documentation in the medical record and also by the ICD code. Was it medically necessary? So basically, in general, your diagnosis code supports the procedure code that you are billing or your HCPCS code, and then also what was documented in the medical record. All of these things, or three items, must support each other to justify that medical necessity. So our overall goals and objectives for today is to identify concepts for correct coding through clear, concise, and consistent documentation by remembering these 10 rules. If it wasn't documented, it wasn't done. And that's something that is general across the board. Any auditor that may come in and look at your medical records, if it's not documented, it's not done, this can mean that your services are being downcoded or even potentially denied, depending on the service. So as part of this presentation, I want to make sure or to reiterate, and you'll hear me say this throughout the presentation, you want to be as specific as possible. You want to provide as much detail as possible because basically you're painting a picture for someone else to get an idea of what happened during that particular patient encounter. Just because there was a code to report doesn't mean you will get paid. Just because there's not a code to report doesn't mean you won't get paid. Again, your documentation is going to justify that medical necessity for providing a given service. As I mentioned, you want to code to the highest level of specificity. You always code what was documented. You don't document to code. And you want to be very careful as far as trying to document to code because that could get you in trouble with the auditors and with the payers if you're not coding what is being documented. So basically, first you're treating your patient, you're documenting what was done, and then you code what was documented. Then you would indicate your signs and symptoms if there's no definitive diagnosis. And basically, for physician billing, your definitive diagnosis will come from lab results, diagnostic tests, radiological services, depending on the situation. Reimbursement for professional coding is not based on a diagnosis, and each encounter must stand alone. So your documentation has to support if you're providing multiple services during a given patient encounter. Each part of that encounter, each service that is provided, has to be able to stand on its own. The documentation must support each portion of that encounter. And the letters and numbers will tell your story. As I mentioned before, your CPT code is supported by your ICD-10 or currently your ICD-9, your HCPCS code, and if modifiers are used. All of these components should support what you are providing in regards to your patient care. So again, just to reiterate, your documentation must be complete, it must be clear, and it must be consistent. Your documentation is used as a legal document, so at any point in time that you have a patient that may take you to court for a malpractice suit, and that's not to say that would happen, but in that situation, you want to make sure that your documentation is as clear, as I mentioned, and as concise as to what was provided. It helps to minimize or prevent malpractice suits. This is the way that you communicate with other physicians or other healthcare professionals. Information within your documentation is used from a statistical purpose, especially with the CDC and NQHA as far as your quality and clinical measures. And again, it's all about medical necessity, which all of these things equals reimbursement. So as you know, as of January 1 of this year, Congress had put into the final rule from 2013 that ICD-10 would be delayed until at least October 1. Well, we did receive clarification or formal notification from CMS indicating that ICD-10 will be implemented as of October 1, 2015. So we have right at a year to get everything together, to get things in motion so that we'll be prepared for when the switch is thrown on October 1. And this was a statement on slide 16 in regards to how much money is costing not only industry but physicians, suppliers, the government, private payers in regards to how much is being spent for ICD-10. It's been estimated that another 1-year delay of ICD-10 would likely cost the industry an additional $1 billion to $6.6 billion on top of the already incurred costs from the previous 1-year delay. This does not include the lost opportunity cost of failing to move to a more effective code set. And one of the things that a lot of people do not recognize or may not be aware of, moving to the standardized code set is a part of HIPAA. A component of HIPAA is the Administrative Simplification Act, and part of that act is to say that everyone who is considered to be a HIPAA entity must use the standard code sets. We basically have to transmit using the standard code sets. That changed in 2012 when we had to change to 5010. And now we're moving towards ICD-10 because this is considered a recognized standard code set by HIPAA. So we really don't have a choice as far as moving to ICD-10, even though the government has delayed it twice. We still have to move to that code set. So this is something that we really don't have an option. It is going to be for the better good for everyone, and I'll get more into detail in regards to that. But this is something that we have to move forward with. It's just like with anything else. We don't like change, and change is difficult, change is hard, but this is something that's going to benefit everyone. So let's talk about ICD-9. What's wrong with it? Well, first and foremost, it's 30 years old, and we've run out of room. As technology has changed, as standard of practice has changed, there's no code. The codes no longer describe current medical policy or current medical practice. So that's the main reason for moving from 9 to 10, because we don't have a way to identify new technology or capture new diseases that are found or track or be able to track outbreaks and things of that nature. So it's basically obsolete at this point in time because we can't add any additional codes. We can't better describe what we're doing. Our documentation may reflect that, but the diagnosis codes don't reflect that. So that's the purpose of moving to ICD-10. So what's the benefit of moving to 10? Well, we have better data. We're better able to describe new technology that's coming out, new disease patterns. We're able to paint a better picture of what's going on with that given patient. It provides a way to better communicate with each other, whether it's with our patients or with other physicians or other healthcare professionals that may be part of the patient's care. So it allows us to better describe, be more specific, code to that highest level of specificity with ICD-10. So in reality, it will help us or provide us with better data. Right now, especially with PQRS, the Physician Quality Reporting System, it will help us to better report those quality outcomes by using or going to ICD-10, coding to that highest level of specificity. It will help us to design better payment systems. Of course, with healthcare reform, things are changing the way that we do business. SGR is like the big gorilla right now, but we're working to change how we reimburse our physicians and other providers. So it's going to help us do that. It'll help you to make better clinical decisions, help with identifying fraud and abuse, whether it's from the patient perspective or the physician or other healthcare professionals, the payer's perspective. It'll help us do a better job of managing our healthcare dollars. And then also it will help research to even be more specific and provide us with better information in order to treat our patients better. So I've gotten some questions as to why not go to ICD-11? Well, the code set won't be available until 2015. However, it took the U.S. about 10 years to convert from ICD-8 to ICD-9. And it's taken us about as long to convert from ICD-9 to ICD-10 because we have to change it to our clinical modification based on the U.S. standards. So it's going to take a while to develop it. And then jumping from 9 to 11 would impact productivity because we don't have that stepping stone. ICD-10 is our stepping stone. It's like our learning curve in order to better document, to better code to the highest level of specificity. So it's going to give us an opportunity to do better. ICD-11 is more specific than 10, but as I mentioned, it's going to take 10 years. So that means if we don't go to 10, we would have to wait 10 years, still using 9. So we're still using obsolete data with an obsolete code set that's not going to benefit us. It's not going to help us better treat our patients, come up with these different clinical guidelines, standard of care. It's going to make it even more difficult. So the notion is not to go to 11, to go to 10. So on the next slide, I think it kind of encompasses everything that I've been talking about. It's bigger than the patient. It's bigger than getting reimbursed. So we're looking at how ICD-10 is going to help us better identify outbreaks, as I mentioned, better patient care, help us to communicate better with each other, population health, patient safety, statistics, and fraud and abuse. So it's going to help us do better at these things that are very important to the healthcare system. So in preparing for ICD-10, let's accept it. Don't ignore it. I know it's hard to not ignore it because you're probably saying, Anita, well, it's been delayed twice, and the government may do it again. And they may do it again, but we're hoping that they're not going to do it again because of the money that has been spent already, and some of you may have already spent this money in getting ready. So we're trying to encourage the government, encourage the private payers. Let's keep moving forward. But as physicians and billers, coders, compliance officers, anyone that's going to be impacted by this change, we need to make sure that we're ready. So you want to be open to change, and as I mentioned, everyone who is covered under HIPAA, which is the Health Insurance Portability and Accountability Act, we are required to move to this new code set because of the law. So who will be impacted or who will be affected by ICD-10? Well, basically anyone that deals with ICD-9. Physicians, nurses, office administrators, front staff, back office staff, IT personnel, data analysts, negotiators, consultants, vendors, payers, anyone that deals with ICD-9 right now will be impacted by 10. Now, some of the processes or systems, forms that will be affected by ICD-10, your insurance policies, your practice management forms, prior authorizations, your practice management systems, your current electronic health records, your coding and billing software, case management system, your registries, anything, as I mentioned before, that's tied to ICD-9 is going to be impacted by ICD-10. And we'll go more into detail later on in the presentation as far as things that you need to think about as far as if you haven't started thinking about the process or things that you need to do to be ready for when October 1 comes, we need to get started. You need to start thinking about them. It may be that you portion things out in chunks because it's going to be very difficult trying to attack everything at one time. But we'll talk about that more in a minute. Now, as far as comparing ICD-9 to 10, the basic change, there are more chapters. Now you can report up to 7 characters versus 5 characters. So that goes to your highest level of specificity, so you get even more specific. With 9, it's mostly numeric, but with ICD-10, it's alpha and numeric. So you'll have a mixture of codes. And you probably get to the point where you start memorizing the codes, just like we did with ICD-9. We knew exactly what codes to use for osteoporosis. You'll know the same thing for 10 once we get used to it. There are approximately 14,000 codes in 9. There will be approximately 140,000, and that's of today. That's going to increase because the set is still being enhanced, it's still being updated, it's still being revised, so that number could fluctuate. But that doesn't mean there's 140,000 codes that you would have to use in regards to osteoporosis and fractures. If you take a look on the next slide, I kind of broken it down a little bit for you. Currently right now for 9, there's 747 fracture codes. You have a range of over 17,000 fracture codes that you'll be able to use. Now, that doesn't mean you'll use all those codes, and as I go through the presentation, the reason for that is it gets more specific. It gets more into identifying the arms, the legs, your hands, your feet, which side, whether it's right or left, whether it's a bone, a joint, whatever the case may be, it gets more into that specificity, which we didn't have in 9. So just because there's more codes doesn't mean that you're going to need to know all of those codes. You just need to identify those codes that are specific to your given practice. So let's take a look at the format briefly. As I mentioned, we're going from 5 to 7 characters, and these characters for ICD-10 may be numeric or alpha character. It will be a mixture of the two. On slide 29, it identifies the first character is always going to be an alpha character for ICD-10. And then the second character will be numeric, and then the remaining characters will be a combination of alpha or numeric. Now, the last character, which is the 7th character, it may be alpha or it may be numeric, and it's required for some of your reporting purposes. Like, for example, to identify if it's an initial or a subsequent or a sequela. With fractures, it depends on whether or not we're doing subsequent care or initial encounter, either for a malunion or a non-union. It really just depends, and we'll talk about some of those 7th characters and where they are applicable in regards to coding for ICD-10. Now, the chapter for musculoskeletal system and connective tissue is chapter 13. And what I wanted to look at or address with you is some of the coding changes or the requirements or some of the things that you will look at a little bit differently in ICD-10 versus ICD-9. Now, on slides 34 and 35, I've listed out for you the chapters that are part of Chapter 13 for your musculoskeletal system, and they're broken down into the various conditions, joint disorders, osteoarthritis, osteoporosis, depending on the situation or depending on your office of what you treat. But I want to go more into detail in regards to some of the instructional changes or your coding changes that have occurred. We're going to talk about some of the coding requirements for site and laterality, acute traumatic versus chronic or recurrent musculoskeletal conditions, coding of pathological fractures, of traumatic fractures, and also specific guidelines for osteoporosis. Now, there are some things that are the same, that have not changed from 9, that are still the same in 10, but there are things specifically that I'm going to go over that you were not able to capture in 9 that will allow you to be more specific, coding to the highest level, painting that picture for someone who may come and look at your documentation to see what's going on with that particular patient. So, as I mentioned, we can capture site now. And based on the definition, site indicates or represents the bone, the joint, or the muscle. And in situations where there's more than one bone, joint, or muscle involved, such as with osteoarthritis, there are multiple site codes that are available. If there aren't any multiple site codes, then you can code or use the codes to indicate the different sites. So you would use multiple codes for those services that don't have multiple site codes available for them. Now, in regards to bone versus the joint, there are certain conditions where the bone may be affected at the upper or lower end, and I provided a couple of situations of vascular necrosis of the bone or osteoporosis. And the thing that you want to take away from this is, even though the portion of the bone that's affected may be at the joint, the site designation will be the bone and not the joint. And this is a new change as far as coding guidelines are concerned. This is the change in 10. Also in ICD-10, it has added laterality, whether it's left or right. And we talked a little bit about episodes of care, initial or subsequent. And we'll talk a little bit more about that as we go further into the presentation. But just to give you a basic idea of some of the changes in regards to laterality have changed. So for acute traumatic versus chronic or recurrent musculoskeletal conditions, it depends on the chapter. Some of the coding guidelines tell you to go to Chapter 13, and specifically for injuries, you have to report out of Chapter 19, and we'll talk about that also later on. So for your bone, joint, or muscle conditions that are a result of a heel injury, you'll code from Chapter 13. If there are recurrent bone, joint, or muscle conditions, also Chapter 13, and then any chronic or recurrent conditions should be coded from Chapter 13. As I mentioned, any acute injury should be coded for Chapter 19, and we'll go into more specifics in a moment in regards to that. One thing that you want to make sure of is if you're unable to determine from the documentation in which the record which code is best described a condition, then you query the provider. So basically, if you can't tell from the documentation what is being provided or the service if you can't tell which joint, which bone, which muscle, you need to ask your physician to get more specific so that you will be able to code the condition properly. Now, currently in ICD-9, pathological fractures are coded using subcategory 733.1 for your pathologic fractures. Now, in ICD-10, these codes for ICD-9, these codes were only used for newly diagnosed fractures. And then the V codes were used to describe aftercare if the patient was receiving routine care during the healing or recovery process or recovery phase. Now, that has changed in regards to ICD-10. So I'll go through the slides and then go more into detail as far as how those changes will impact you as far as coding. So we talked about the 7th character. The 7th character goes more into detail as far as whether it's an initial encounter or subsequent encounter, sequela, malunion, non-union, whatever the case may be. So with pathologic fractures, the 7th character represents, or character A represents when the patient is receiving active treatment for the fracture. And I've provided some examples. Now, these scenarios have not changed. Examples of active treatment for examples of active treatment are surgical treatment, emergency department encounter, or evaluation and treatment by a new patient. This has not changed. This is the same as you're doing it today. So that hasn't changed. It's just now that you'll have a seventh character, A, to identify exactly that the patient is getting active treatment. Now the seventh character, D, indicates where the encounter is after the patient has completed active treatment. Now, there are other characters or other seventh characters that go more into detail. They're used for subsequent encounters, as I mentioned, for treatment of problems associated with healing, such as malunions, non-unions, and sequela. Now, one of the key changes from 9 to 10 is care for complications of surgical treatment for fracture repairs during the healing or recovery phase should be coded with the appropriate complication codes. So that's a little bit different as far as what is being done now in ICD-9. Now, in regards to traumatic fractures, in 9, these were coded using the acute fracture codes, ranges 800 through 829, while the patient was receiving active treatment for the fracture. As I mentioned on slide 41, there's an example of the active treatment. So this is, as I mentioned before, this is the same for 9 as it is for 10. But how you report it now in 10 is going to vary. Fractures are coded using the aftercare codes, which are currently V codes, V4.0, V4.1, V4.8, or V5.9. And this represents encounters for routine care for the fracture during the healing or recovery process. And some of the examples of aftercare, and which is the same as it is now in 9, is also the same in 10. If there's a cast change or removal of an external or internal fixation device, if there's a medication adjustment, any follow-up visits during the fracture treatment. So for 10, in regards to coding of traumatic fractures, these codes are taken from Chapter S, which is basically Chapter 19. I'm saying Chapter S, but from Chapter 19, which is basically for the injury section. And these are the subcategories that you may use or would use to indicate your traumatic fractures. There may be instances where you may have multiple fractures, and you would assign the separate codes for each injury unless a combination code is provided. So it really depends on the situation. And then you sequence that information based on the severity of the fracture. You also will be able to identify fractures of specified site or specific sites. So you need to make sure that these codes or the sites are coded individually. So basically you will have more codes to identify multiple fractures, multiple sites. There may be codes to a combination code to represent those multiple sites. So you want to make sure that you're capturing all of this information. As I mentioned with the traumatic codes, they also have a seventh character that identifies the initial encounter, and I've outlined what those particular seven characters may be for your traumatic fractures. And if you'll notice, the descriptions may change. So you can't depend on or remember that A is always this particular description. It will vary depending on your patient's condition. So for traumatic fractures, A represents initial encounter for a closed fracture, B is initial encounter for an open fracture, and then C is the initial encounter for open fracture types A, B, and C, or C. So with the seventh character, it's going to identify those complication of fractures, as I mentioned before, such as your malunion and non-union. And I believe on a couple of slides down, we'll see that. Well, actually, the next slide. Subsequent care with a non-union, it identifies the specific seventh character, which it will be applicable to. So you want to make sure you code into the highest level of specificity. And this is also captured on slide 46. Now, the difference between 9 and is instead of using V codes to describe your aftercare codes, it does indicate, or it requires you not to use Z codes, which are currently used for aftercare. So you have to use the appropriate 7th character. So instead of, and let me back up, instead of using the V codes to describe the aftercare, you use the 7th character depending on the situation, whether it's a subsequent encounter, initial encounter, whether it's a malunion or a non-union, whether it's an open fracture, whether it's a closed fracture. This will be described using the 7th character. So you don't want to use the aftercare codes or the Z codes for aftercare for your traumatic fractures, because your 7th character will capture that information for you. Now, in the coding for osteoporosis, the category code is M80, and this is osteoporosis with current pathological fracture. So a little bit different, some of the guidelines that are different from ICD-10, this identifies the site of the fracture and not the osteoporosis. And this is used for patients who have a current pathological fracture at the time of the encounter. That requirement is the same as ICD-10. It's used for patients with known osteoporosis who suffers a fracture, even if the patient has had a minor fall. So that's a little bit different than how you code osteoporosis right now. Now, osteoporosis without a pathological fracture, this is used for patients with osteoporosis who do not have a pathological fracture due to osteoporosis. Now, in the situations where you have patients that have a history of osteoporosis fractures, it will be appropriate to code Z87.310, and that's for the personal history of heel osteoporosis fracture, but that may vary depending on the situation. So that last digit will further explain what's going on with that patient. So how do I prepare for ICD-10? Well, these are some general concepts or recommendations from CMS, and these are things that I also reinforce or reiterate to groups that I make this presentation to. You want to identify all of your current systems and work processes that use ICD-10. As we discussed earlier, we talked about a lot of things, who would be impacted, what would be impacted. So you need to do an analysis of your workflow, how things, as far as whatever ICD-10 touches, you need to look at that and how it's going to, or what changes you need to make for 10. For example, you will need to change your encounter form. If your encounter form has any ICD-10 codes on there, you're going to need to change those. And you may have multiple codes. So you would need to identify if I need to list out all of these codes, are they relevant to my practice, or if it's just, or pinpoint those codes that are specific to your practice. So you want to make sure that you go through that process. You need to look at your ABNs. You need to look at your practice management systems. As I mentioned, your electronic health record systems, your EHR. You need to talk with your practice management vendors, your EHR vendors, and make sure, hey, are you ready for ICD-10? Have you started testing? When can I start testing with you to make sure that the information that I'm transmitting to you is being transmitted properly to the given payer? And don't just take it or assume that they're going to make sure that everything works. Reach out to them. Ask them questions. When are they planning to test? When are they planning to upgrade your system? Because this is going to be an impact to your office in regards to how productive your office is going to be, cash flow that is going to be coming in or out. So you want to make sure that they are ready. Discuss implementation plans with your clearinghouses, your billing services, and your payers. Again, you need to find out where are they. Find out where your payers are as far as them being ready for ICD-10. Right now, CMS is ready. CMS was ready for the switch to go off in a couple of weeks. But because Congress mandated that they wait until next year. CMS is on hold. A lot of the private payers were ready. So you want to reach out to them if they haven't put out information to say these are the dates we're going to test, or if they're asking for volunteers. If you see those notices out there, volunteer to see how your claims are going to go through. So if there are any hiccups in the system, you'll be able to fix that, or your vendors will be able to fix that prior to the implementation date. Talk to your payers about how ICD-10 might affect your contract, specifically your private payers, your Medicare Advantage payers. You want to see if there's anything within those contracts that may impact you in regards to ICD-10. I've already talked about your workflows, your business flow. You also need to identify your staff training needs. And don't think that your front end or your back end staff don't need some type of training. It may not be to the extent of what you may provide to your physicians, your practice managers, your coders, your billers, your auditors, but they need to have some idea of what these codes are, what they look like. Budget for time and costs that are related to implementation, including expenses for system changes, resource materials that you may need, training. One of my members of my committee for the American Association of Clinical Endocrinologists, they wrote an article on the impacts of them getting ready for ICD-10. One of the things that he brought out, which I believe is a very good idea, you want to make sure that you have a cash reserve, at least for 3 months. Because normally with ICD, if you're very familiar with how ICD, the diagnosis code changes work, usually there's a 3-month lag. And you may have codes still that you would need to bill ICD-9 and then codes that you would need to bill ICD-10. If there's any delay as far as how those claims are being transmitted, it's going to impact your cash flow. So you want to make sure that you'll still be able to pay your staff, pay your overhead expenses, be able to buy supplies, devices, whatever the case may be. You want to make sure that you have a reserve so that it won't impact your office as far as cash flow is concerned. And again, as I mentioned, you want to make sure that you're conducting testing transactions with your payers and your clearinghouses. So some of the consequences for poor preparation, increased claim rejections. If you're billing ICD-9 where you should be billing ICD-10, this is going to cause your claim to reject. Denials if you're not using the proper diagnosis code. As you know, with some of the local coverage determinations and the national coverage determinations, they require specific diagnosis codes. And if you're not using the right code or coding to the highest level of specificity, it could cause your service to deny. So you want to make sure that you are using the appropriate code. It could increase delays in processing authorizations, especially with your private payers. A lot of the services, diagnostic tests, lab tests require prior authorizations, or surgical procedures require prior authorizations. So if you don't have the appropriate documentation and the right diagnosis code, this could cause a delay. It could cause your claims to pay improperly. It could also impact coding backlogs, compliance issues. So that's why I mentioned, you have to look at all aspects of your workflow process. If you have internal audits conducted, you need to make sure that all of that process is evaluated. And it also could cause you to make incorrect medical decisions as far as your patient's care if you have the wrong data. So you want to make sure, as I mentioned before, and I've mentioned several times throughout this presentation, that you want to code to that highest level of specificity, and you want to make sure that you're reporting the right diagnosis code to describe your patient's condition. So some things to remember in regards to ICD-10, and this is something that you need to discuss with your vendors, whether it's your practice management, your clearinghouses, your billing services, your EMR, your EHR vendors. they have to have the capability to bill both 9 and both 10. And the reason for that is you have to be able to bill for those dates of service up until October 1. So if you have claims that are before October 1, you should be billing ICD-9. And then any claims October 1 and after, you will bill ICD-10. But your claim system has to have that capability to process both those 9 and 10 claims, because your process may, depending on your process, you may bill claims weekly, you may bill claims biweekly, you may bill claims monthly, so that will make a difference as far as which diagnosis code should you be using, 9 versus 10. So if, for example, if you have a situation, let's say you have a patient that's had surgery and they're spanning dates. Let's say that patient was admitted on September 28th, but they were discharged on October the 1st. You're going to have to split the claim. So you would have two separate claims, basically claims. One claim would have the September services, and then one claim would have the October 1 services or after. So you need to make sure that you do split your claims. If you don't split your claims, your payers are going to kick it back. They're going to return them as unprocessable, and then you'll have to resubmit them over again. So you want to make sure that you're aware of those span of dates. That's something that you want to make sure that your billers and your coders are aware of, so that they are inputting that information correctly and won't cause a delay in reimbursement. So let's look at a few clinical documentation improvements. And these are things that you can do a little at a time, because you have a whole lot that you need to be thinking about in regards to ICD-10. You're thinking about, how am I going to get all of these forms that I use updated, how I'm going to get all of my software updated, whether it's my practice management system, whether it's my clinical decision-making system, whether it's my EHR. How am I going to train my patients? How am I going to train my staff? How am I going to train myself to make sure everybody's on one accord? But these are little things that you can do, and take chunks at a time. You don't want to tackle, especially with your documentation, you don't want to look at all of your diagnosis codes and try and make those changes at once. You want to, for example, maybe focus on osteoporosis and then make the changes if there are any. You may already be where you need to be for documenting your ICD-10 services, but if you're not, take a look at your documentation, see where you can enhance it so that it will support the ICD-10 code. So when an auditor comes in, they can't question what's being documented versus the patient's diagnosis code. So as far as your clinical documentation improvements, basically the goal is to improve your documentation to make sure that it doesn't have any impact on your revenue. As I mentioned before, poor planning could cause denials, it could cause delays in treatment, it could cause delays in payment. So these are some things that you want to make sure that you're taking into consideration. Some of the impacts of poor documentation, it impacts the quality measures, not only CMS, but with the private payers, the pay for performance measures that they have, PQRS, data that is used to treat the patient. This could have an impact, but it will help reduce compliance risk, as I mentioned, especially with auditors coming in to look at your medical documentation. There's audits from all aspects, from whether it's from the private payers to Medicare, whether it's your individual Medicare administrative contractors, or it's the RACs, the recovery audit contractors, who's the big brother to the MACs. So you have all these people looking at you, and you want to make sure that you don't give them any room to poke holes in. You want to make sure that your documentation is as clear and concise and as specific as possible. So some things you need to think about as far as fractures, and I'm just going to talk very high level. This is not an inclusive list as far as some of your documentation improvements, but these are just some of the things that I looked at that I thought would be helpful during this particular presentation. So for fractures, you want to make sure that you either indicate it's open or it's closed. If it's not, the default is closed. If it's not indicated as displaced or non-displaced or displaced, you code it as displaced. So one of the enhancements maybe is if you don't indicate whether it's open or closed, that's the improvement to your documentation. Indicate that it is an open fracture if it is a closed fracture. You don't want to make an assumption or assume that the auditor knows what you're talking about. You want to be, unless it's easily inferred, you want to be as specific as possible. So those are a couple of things. Specifically to a given condition, like for osteoporosis, it's with or without pathological fracture. Is it age-related? Is it drug-induced? Is it postmenopausal? Getting more specific, looking at the shoulder and upper arm just to show you how ICD-10 provides that more specificity, that higher level of detail. Looking at the clavicle, whether it's anterior or posterior. If you're documenting that now, that's great. But if you're not, this is a clinical documentation improvement. This is how I can enhance my documentation. With the humerus, whether it's transverse, oblique, spiral, whatever the case may be, it helps you to be more specific. These codes will give you that more specificity that the payers are looking for to show that medical necessity. Just keep in mind, it's all about medical necessity. Some additional clinical improvements, and as I mentioned, this is just a few that I looked at. With the radius, whether it's the head or the neck, the femur, whether it's the base of the neck, the head, depending on which part of the femur we're talking about, like with the ulna, with the Alcran process, just depending on what it is, you have codes that make it more specific. With ICD-9, some of these codes were not as specific as with ICD-10, so it helps you to be more detailed. As I mentioned before, you don't want to take on each disease state all at one time. Focus on a couple. It may be a project that you assign to your staff for them to focus on and to make those documentation enhancements for you. And this will help you to better document your services, again, meet that medical necessity that all the payers are looking at. It's all about medical necessity. So just to reiterate some of the things that you need to think about during the transition, you want to develop an implementation plan and communicate that new system changes to the organization. So you want to make sure that everyone, whether you are a solo practice, a multi-specialty practice, or if you're part of a facility, and for the most part, if you're part of a huge health system, they do a lot of this, but you want to be aware of what's going on. Are they doing the things that they need to do? Are you getting the education that you need as a physician, or if you're the practice manager or the coder or biller or compliance officer, you want to make sure that this information is being communicated and that everyone is on the same page. Ensure that your leadership and staff understand the extent of this transition. And as I mentioned, you want to secure a budget. Whether or not you need to do upgrades, you need to find out from your vendors if this is going to be an additional cost. If they are going to do testing, you want to make sure that they are testing so there won't be any cash flow impact to your office. Take into account staff training. Workflow changes during and after implementation, and any contingency planning. As I mentioned before, one of my members, they had a 3-month cash reserve just in case anything went wrong. I mentioned this already as far as talking with your payers, your billing, IT staff, vendors. Make sure that they're ready. Coordinate your ICD-10 transition plans with your partners. Look at your contracts, look at your timeline. You want to develop timelines to make sure that each component is met or each milestone is met. And as I mentioned, you may have or have the capability to have a team to do this specifically. or you may have to break this up in chunks and assign this out to your staff to help you get through this transition. On the next few slides, there are some educational resources. This is through Medscape. There are ICD-10 free ICD-10 video lectures on general topics, and I know that there are some on specific topics. Medicare offers a checklist implementation guide, specifically whether or not you're a small practice, a medium practice, or a huge practice. It gives you specific things to take into consideration as you go through the implementation process. I would suggest that you sign up for CMS's listserv. They're always providing updated information in regards to where they're at with ICD-10. They provide educational webinars, online resources that you can refer to help you through this process. There's a lot of information out there. In addition to that, ACE also offers, if you're interested in attending any of our courses, we do webinars and seminars. Also, the Practice Management Institute provides these training sessions specifically. It could be specific to osteoporosis or musculoskeletal system connective tissues. They do have those specific type of training sessions. And then you can also do training as you go. The World Health Organization, which is responsible for developing the diagnosis code sets, they have an online module that you can walk through at your own pace to get your staff implemented, acclimated, and also get yourself acclimated and aware of what's going on. What is ICD-10? How is it going to affect me? How do the new codes vary from the old codes? What do I need to do, as I mentioned earlier, as far as documentation improvement? So it will help you or guide you through this process. If you do have any questions, please feel free to contact myself or my staff in regards to ICD-10. And I want to thank you for your time. And moderator, I will take questions at this point.
Thank you, Anita. Ladies and gentlemen, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. If you wish to ask a question live via the phone, press *1 on your telephone keypad. I will announce each caller prior to bringing you into the conference. Please remember that if you have your phone on mute, take it off mute when you are selected to ask your question. Once again, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. To ask a question live, press *1 on your telephone keypad. Anita, we have no live callers at this time, so you can see if there's any chat questions.
Okay. I know I see a lot of questions in regards to if the handouts will be available. They will be available. I will send this information to Debbie, and I believe she will be able to post this information on your website. As I mentioned, if you have any questions after this session, I am available to help you through this process. Endocrinology is a little bit different than dealing with fractures and osteoporosis and other musculoskeletal conditions, so it's a little bit more complex. But I am available to assist the attendees with this. If there's any questions that come up after the session, I will make sure that I will get those answered and get those back to Debbie so that she can publish them.
All right. Anita, it looks like we do have a question from Tony that talks about more specifics about vendors and types. Would you like to address that now or during the after the presentation's over?
Oh, no, we can address that now. That's fine.
Okay. So that's the question. More specifics about vendors and what types.
I'm sorry. I thought he was going to be on the line. I'm sorry. As far as the vendors, if you already have a EHR vendor, one of the things you want to do is contact that vendor to see if there's going to be one additional charges as far as updating your system. Some vendors already have it as part of your current contract that they will automatically make any adjustments. So you want to make sure that that is not going to be an impact. You'll need to, identify those additional costs, as I mentioned, if they are going to charge you for a software upgrade. You also want to make sure, as far as when are they going to start testing, have they been testing, ask them for a timeline. One of the things that a lot of the vendors are doing is posting or sending out emails as far as timeline, as far as when they're going to start testing with the payers, when they're going to start testing with you. So you want to make sure you have their timeline so you can back into your timeline things that you need to have ready to go when it's time to start testing. And I hope I answered your question. I didn't know if that was the direction you were going, or was there more specific information you were looking for?
Thanks, Anita. Jerry asks about paper charts. How will this hurt the practice?
As far as paper charts, well, really, with your paper charts, it's almost the same as with your EHR. You're going to have to look at the paper chart to see how ICD-10 is going to impact it. So really with the paper charts, you're looking at how you're going to do your enhancements. What in the paper chart can I do better to describe my patient's condition? Is it like with osteoporosis now where you have codes to identify if it's drug-induced or if it's age-related? Am I capturing that information now? If I'm not capturing that information now, then I need to start capturing it. The same would be true for electronic records. There really isn't no difference as far as your documentation is concerned. You just want to make sure that you are being as specific as possible. So if you're not at that level, now is the time to start. As I mentioned before, you just want to take pieces at a time, take chunks of, let's say, your top 50 codes and start breaking them down into chunks, whether it's osteoporosis specific or fractures or whatever the main category is. You want to start looking at that to see how you can better enhance your paper charts from that perspective.
Thanks, Anita. Ladies and gentlemen, as a reminder, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. To ask a question live, press *1 on your telephone keypad. While we're waiting, Anita, anything else you would like to share with the audience?
I would just reiterate, this is a big implementation. Some people compare it to Y2K, even though that wasn't too bad. But it's just going to take time to work through or look at all of your work processes, your workflows, going through your various systems to make sure that you're looking at everything that could potentially be impacted by 10. We don't want to wait until August to start doing this process. That would really be a huge impact. You want to start looking at this now if you haven't already begun the process. We have another year, so I would initially first develop your implementation plan. What do you want to tackle first? And identify those milestones and make sure that you stay on top of those milestones. Whether, as I mentioned, whether you assign this to someone or you do it as a team within your practice, depending on the size of your practice, you just want to make sure that you stay on point and you stay on task and don't get discouraged or distracted because of the changes that you may need to make in regards to ICD-10 implementation.
Thank you, Anita. I'll now throw it back to you, Debbie, for final closing remarks.
Thank you, Anita, and thank you all for joining us today. I just want to let everyone know that today's webinar will be available on demand on Fracture Prevention website in the next week. We really hope you enjoyed the presentation and would greatly appreciate your feedback. You will be receiving an evaluation, and any comments, suggestions that you have, we would very much like to see. And we hope that you can join us on October 1st for our next webinar, which will be Introduction to the NOF and BHA Qualified Clinical Data Registry. Thanks so much, and I hope you all have a great afternoon.